Welcome to the Athlete's First Performance Podcast, where two performance minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, welcome to episode 4 of the Athlete's First Performance Podcast. Today we're going to be talking about how we evaluate and treat the shoulder. We'll move into the history, the examination, the state of the special test, and then our management strategies. How's it going, James?
I'm good, Josh. Another good morning. Got a good workout in and hopefully going to play some golf this afternoon, hit the driving range. How about you?
You're doing more than I'm going to be doing. We had a busy weekend last weekend, so it's kind of laying low this weekend. But yeah, so do you want to go ahead and jump into it, starting with how you would take a history of someone that comes into the clinic with a shoulder issue?
Yeah, so I think the first thing is getting that subjective exam, and the history is something that I've put a lot more focus on over the past, I guess we've been practicing for 4 years now. So over the past like 2-3 years, really been focusing on more of that subjective exam. Early on in our career, or in my career, I would have a pretty short subjective exam and then go right into all the different objective special tests. But I found it's a lot better to get a sense of where the patient's at, where they're coming from, and what their goals are with the history. So first thing I'll do is when someone comes into the office or the clinic, I'll just ask them, what brings you in today? And then they'll probably get into their long story of what's been going on with their shoulder. And the biggest thing that I try to get to right off the bat is their symptoms. So I like using a pain chart or a body chart and really get their primary symptom. So I'll get their primary symptom and get a sense of, okay, what aggravates it? What eases it? Where does it start? Does it travel anywhere? And how would you describe it? So I'll write that all out on line one. Then I'll ask them, okay, are you having any other pain? Are you having any pain in your neck, your shoulder blade, radiating down your arm? And just go through that same process for each of their main complaints. So that gives me a way to objectively track that throughout the treatment and plan of care to determine, okay, if there's one spot in the shoulder is getting better, but it's not improving in their thoracic spine, are we dealing with the same thing? So getting a little bit more specific with that type of history is something that I've been really focusing on. And then also going into, once you get a sense of how their shoulder, what aggravates it, what eases it, and where their symptom locations are, then I'll go back in terms of their original mechanism of injury, how long this is going on, their previous care, and what's worked for them in the past. Anything specific that you do?
Yeah, so I guess I've been playing around with this too. So I like the idea of getting their symptoms and kind of location of symptoms and quality of symptoms right away, because then it gives you a bit of a foundation on how I guess you can put together that story. I typically will go into, I'll say the same thing, like what brings you into PT today? And then I kind of just let them go and just let them talk and kind of glean what I can from that initial story. And then I'll follow up with the questions, of things that they didn't speak on. Sometimes that can get, it depends how long you have for your eval, but that can get pretty, depending on the person, that can get pretty intricate and can be quite a long story. So maybe some redirection at times, but yeah, so I let them just kind of go in the beginning, and then I'll, if I need to ask their mechanism, how long, I like to get an indication on what previous treatment they've had. Mainly to know, like, if they've had PT before, I'll always ask, well, did it help? What did you typically find helpful? What did you find not helpful? Kind of get an idea of what they're open to with my treatment. Obviously the symptom description, location, I'll get their easing and aggravating factors. And then I'll try to get a sense of just what they know about their issue. Sometimes if they've had previous medical care, they've been educated in a certain way, or maybe they've seen multiple people and they have multiple stories for why their issue is persisting or why they injured themselves in the first place. And I try to get an idea of where I can start to educate, because some of the education that's happening can be quite I guess, detrimental to the person's ability to recover. Um, I get a history of their injuries. So, like you said, if they've had multiple injuries, that can predispose them to having another injury. But also, if they've had injuries to their neck or their thoracic spine or anything else that may relate to the shoulder, that's good to know. And then get an idea of what their activities are, things they want to get back to, just to help with goal setting in general. But yeah, I like the idea of trying to get the symptoms first because it kind of just gives you the synopsis of why they're in, and then you can get an idea of the whole story after that. So I play around with it. It may depend on the person. So yeah, those are kind of my big points. But it helps you. I mean, if you get a good history, it helps you streamline your exam because you kind of know, if someone's going to have radiating pain, it's like, well, I need to look at the neck and maybe some neural tension testing and things like that. If it's just shoulder pain, depending on location, if you get an idea if they're, an overhead athlete, that's going to kind of direct you. So yeah, the history is by far my most important, kind of what I place the most emphasis on in the exam.
Yeah, for sure. And something that I've been focusing on and something that we talked about in residency and fellowship is after your subjective exam, you should have 2 to 3 hypotheses. And your job with that objective exam is to either refute or accept what you're thinking. So going through it like that really has helped my clinical reasoning instead of just, okay, going through a general history and then I'm just going to do every single objective exam and then I'm overloaded with information. So if you already have those hypotheses, you can go ahead and test certain things and be able to quickly rule in or rule out what you're thinking.
Yeah, and I think that's important. You kind of want to prove yourself wrong, and eliminate things before you. I mean, you might have your thing like this is probably anterior instability, or this is probably a rotator cuff issue, or whatever. But proving yourself wrong so that you're not biasing yourself towards a particular thing, so you don't miss something. And yeah, I think that if you do that, you're going to have a much more accurate approach to treatment in the beginning. But I also wouldn't say, I mean, you should have hypotheses after your history, but sometimes someone comes in and they're all over the map and it's like, I have no idea. And at that point, I'll move into and we can talk about this now because we're going to exam. I'll move into just active passive. Let me see them move, and do some resistive testing. And that'll give me at least a start for treatment. And then sometimes it just takes a little bit of reflection after the person's session is over to figure out or kind of put that puzzle together of what may be going on. And sometimes what you officially quote unquote diagnose them with, it doesn't matter because the treatment's going to be the same of the different objective findings that you found. So yeah, let's go ahead into examination. I guess we can start with just general what you're going to look for. I know you do things a little bit differently than me, and then we can get into the world of special tests.
Yeah. So my first part of my exam is just observation. So depending on who I'm working with, like if it's an athlete or overhead athlete, or even someone that's very active and they're okay with like taking their shirt off, especially if it's a guy, I'll have them take their shirt off. That way I can be able to better observe for any type of atrophy in the rotator cuff. I know it's not super specific, but their scapular alignment and their head and neck position. So those are just general things that I like to take a quick look at. It may or may not change what I do, but just being able to observe that is something that has been helpful. And then after the quick observation of just head, neck position, scapular position, shoulder position, I'll go through the top tier of the selective functional movement assessment. So there's 7 main movements. We might not have to go through the specifics of that, but you're checking everything from cervical active range motion, shoulder active range motion, multi-segmental flexion, extension, rotation, single leg balance, and squat. So I'll go through all those top tier movements with most everyone that can handle that, just to get a quick assessment of how well they're moving. And then that will help guide me in my exam. So always looking at active range motion versus passive range motion, going through the different breakouts of the SFMA. I'm not sure how much we want to get into that, but how about you? Why don't you take us through your exam?
I was gonna say, so we can do a whole podcast on the
Yeah.
SFMA and FMS. But that's interesting because it is important, particularly when you're talking about more of the athletic population, whether it's golfers or throwers or swimmers. It's good to get an idea of how they move the whole body, because it is sort of a lot of their movements are going to be full body, I guess you could say. It requires the full kinetic chain to move appropriately, and if it's not, then you might see more stress to a particular area. So that's good. Observation for me is first, depending on the person, obviously, but I think, being able to see the whole shoulder is important. So if someone comes in and they're wearing a hoodie, like if they're wearing a tank top, that's super helpful. But if they're comfortable, particularly like you said, a male, removing the shirt. If not, you could put them in a gown if you have one, uh, just so you can see the whole shoulder. And if not, then you just kind of work around that. I like to go palpation next, just because that helps me get an idea of just location of pain. Whether there is increased sensitivity to pressure, or even light touch, that'll give me a lens into if there's any sort of sensitization going on. And then I just think that I have a lot of patients that come in and they've seen a provider previously, and either like, they never even touched my shoulder. Like so that touch piece is just important from that patient perspective. So it's kind of multi-dimensional on how it helps. Then I'll move into active range of motion, and then we'll get into passive range of motion once they're laying down. So once I see their active range of motion, if it's full, I probably don't do a ton of passive. I'll do rotation, external and internal rotation passively, because it's just kind of hard to move through your full available external and internal rotation. But if someone has full flexion and full abduction, I'm not too concerned with looking at that passively. Occasionally I look at joint mobility just with some A to P mobilizations. That's going to be more in the population that might have issues with maybe a frozen shoulder or something like that, or just a stiff shoulder. I place a big priority on strength testing, probably more than special tests, even though some special tests are basically strength tests, because that gives me an idea of what muscles we may be dealing with. If I test, for example, if I test the infraspinatus or just generally external rotation, they have weakness and pain with it, that's kind of something that I want to target. And so I think strength testing, regardless of what you're checking, can be really helpful in directing that treatment. I guess I should have said first, screening the neck is always a priority. Just looking through cervical range of motion, doing a Sperling's test, a distraction test, just that little cluster that can rule in cervical radiculopathy, and then just functional movements. I guess for what you do is the SFMA, and I'm not as adept at that, and I don't use that like you do. I guess I don't really use that at all, but I see the benefit of it for sure. Is just looking at them perform, if they're comfortable, that activity that they have difficulty with. So whether it is reaching overhead to grab something, or reaching across their body, or picking something off the floor, or whatever it is, just looking at what that looks like. Without any cueing or anything, just to see, because that'll give you an idea of how they move or how they injured it in the first place.
Yes.
So yeah.
Oh, yeah.
So go
And
ahead.
and the SFMA isn't anything mind blowing. It's just a systematic way to actually break out different movement patterns. So in terms of shoulder specific movements that they do like a functional overhead reach. So bring your arm overhead to touch your opposite shoulder blade. Then they do a functional internal rotation reach. So just reaching behind your back, again, to touch your opposite, like inferior angle of your scapula. So that's just a quick assessment in the top tier. And then if there's pain or there's compensation, or they're not able to actually reach those landmarks, then you go ahead and break out with the overhead reach. You break out their first thoracic spine. So you never know if you're dealing with, if a person has decreased thoracic spine extension rotation, that might be the main reason why they're lacking shoulder mobility, or they have a painful shoulder. So you're breaking out thoracic spine rotation, making sure that that's off the problem list. And then you can go ahead and break down those specific movements to their three different parts. So reaching overhead is a combination of flexion, abduction. So you go through that actively prone on the table, then you do it passively. So are they able to do it? Or so yeah, if they're able to do it actively, then that'd be more of like a stability motor control, because they're laying down, there's less stability requirements versus standing. But if they passively can't get up there, then you know there is a shoulder flexion, abduction, mobility dysfunction that you need to work on. Same thing with external rotation and internal rotation. So I do it prone, um, with their arm hanging off the table, see if they can actively get into 90 degrees of external rotation, and if they can actively get into at least 60 degrees of internal rotation. It may or may not be different with a throwing or overhead athlete, but those are the main range of motion requirements that I'm looking at. So if they're lacking those specific movements, that'll help guide me in terms of my local exam of the shoulder with like joint mobility testing, muscular length assessments. So it just gives a deeper dive into what exactly you need to work on, and be more of a sniper versus just having a whole bunch of things that you may or may not need to work on.
Yeah, shooting with a shotgun versus a sniper.
Yeah.
A sniper. No, yeah, I like that. I think it's super important to have a systematic way to go about it. And regardless, whatever that is. And like you said, a lot of these different movement screens have, the name to them, but really you're just trying to get a systematic way of how you want to funnel down your examination. My systematic way, I guess you could say, is just based on the patient position. So I try to go from, as best I can, like standing, seated, supine, and then prone. So I'm not necessarily checking all of my strength all at once. I'm going to check certain positions in seated, certain positions in supine, certain positions in prone. And I don't really care about the position against gravity for the traditional manual muscle test. I just want to see what they can do with the position that either is their aggravating position or just in general, how I could test that muscle with ideally the least compensation possible, just so you can kind of isolate that area, but if you can. But I also think how you use the SFMA is good because no one moves in just a sagittal, frontal, transverse plane. And a lot of the traditional exam and kind of a lot what we learned in school was pretty much like, let's check the external rotators, let's check flexion, abduction, but looking at a combination, combining different planes of movement is how we move in real life. So that's extremely important. And a lot of times when you do your treatment, particularly strengthening, you are moving from that straight plane exercise techniques to multi-plane, whether that's like diagonals or whatever. So yeah, I like it. I think whatever you can do to get a systematic way to approach any sort of examination means you can apply that system to anyone that comes into the clinic and then just alter it based on their history or their presentation. So yeah, I totally agree with that.
Yeah. And one more thing that we didn't talk about is the patient's severity and irritability of symptoms. So you definitely, before you go into your objective exam, you definitely have to get a sense of how intense are their symptoms and how easily are those provoked and how easily are those symptoms relieved. So if someone has high pain that's easy to provoke and doesn't go away, that's going to be a very limited exam versus someone that only has pain with a specific movement or motion that goes away pretty quickly. So you definitely don't want to over examine someone and then flare them up, and then they won't want to come back in, or they'll be pretty unhappy with you the next time they come back in to see you.
Yeah, no, that's actually a really good point, because you need to really get the, if they're high severity or irritability, you need to get ideally the minimal amount of information that you can get, ideally trying not to provoke symptoms to then start treatment. And the other piece of that too is if someone comes in, they're highly irritable or they have high severity, or they have signs of central sensitization, your testing and stuff's going to be all thrown off. So at that point, it's like you got to find what they're comfortable with and start there. So if someone's high pain, everything's going to hurt. So if you're using pain provocation as a way to decide if, a test is, again, quote unquote, positive or negative, that's got to be basically thrown out the window.
Yeah, exactly. So we've talked about screening the neck, making sure that the neck isn't the cause of the symptoms, active, passive range of motion. What do you feel, or how do you feel about manual muscle testing, grading versus seeing how much force they can produce versus pain, or a combination of all of them?
I guess I don't use, like I said, manual muscle testing in the traditional sense. If I test someone's, but if I test a particular movement in the examination, then I'm just gonna, to check progress, repeat that motion, not necessarily like, a specific manual muscle test. So whatever position I test something, and I'm just gonna repeat that for like a progress check.
Mhm.
Um, I don't, like I said, I don't really worry about putting them in that position against gravity and having them move and then having me move them and then checking the strength. Kind of how like we were taught in school, that takes a lot of time. So yeah, I think grading or objectively measuring that is important just for progress measures. And that may be mainly for those that come in with, like workers' compensation or something where you have to show some objective improvement. But yeah, I mean, the grades we know aren't accurate. They're very
Mhm.
subjective. And I don't know what the reliability is, like, within the PT, I guess, the interrelator reliability. I don't know how strong that is, but I'm sure it's not great, especially if you're doing a progress note 6 visits later. I do like the addition of the dynamometers and things like that if you
Mhm.
really want to get it. And I think patients really like to see what they're pulling or pushing or whatever. There is a little bit of inaccuracies with the handheld dynamometers and things like that, but if you anchor it to something, I think that that's a really good way. And then you repeat it the exact same way. That's a really good way for patients to see. It's like, oh, I could pull 20 pounds and now I can pull 40 pounds or whatever. And it also is something, and I heard, we'll talk about Adam Meekins a lot in this podcast. He was kind of saying that, if you have a patient that's fearful, and this may be going off on a tangent, but you have a patient that's fearful to, you know, pick up 10 pounds and you say, all right, well, let's just come pull on this dynamometer. And all, there's no way to gauge how hard they're pulling in their mind. And all of a sudden they're pulling 40, you know what I mean? So
Mhm.
I think the dynamometers are really useful if you have them. The only, I guess, con of that is trying to rig it up so that you can check it appropriately so that there's like a, it's anchored to something or it's sturdy. So you're not just relying on me holding it without any sort of support. And then you pushing into it. So that can get, once you get a system, maybe that can be helpful, but that can get kind of tedious having to move around and figure out how to test abduction or external rotation in, certain positions. So to
Mhm.
sum it up, I don't really use manual muscle testing in the traditional sense. I do it to check just general weakness side to side, and then pain provocation. I think grading it in a certain way objectively is important, and the best way to do that would be using a dynamometer.
Yeah, I agree with it. In terms of manual muscle testing, I don't really care about the grade. I want to know if it produces symptoms or not. And then kind of like the dynamometer, I've been using that Tyndek device as well with shoulder internal external rotation at 0 degrees and 90 for more of my active patients or athletes. So that's something, sometimes not the first day, just depends on how much time we have, but that's definitely something that we assess and track over the course of the treatment, as well as a handheld grip dynamometer. So those most clinics have those. So I'll test right versus left at like 90 position at their side, and also test straight overhead. So ideally, they should have more grip strength overhead. But if they have a painful shoulder and they're not able to produce as much force because of pain in an overhead position, that's something that's very easy to track over the course of treatment. I'll use that for pretty much any patient that I see that has neck or like upper quarter pain, just testing grip strength in that
Oh,
below 90 and overhead position.
so when you say 90-90, do you mean like, do you mean just like 90 degrees elbow
Oh yeah,
flexion?
yeah,
Okay,
yeah. Not
just to
90.
clarify.
Yeah. 90
Um,
degrees of elbow flexion by their side.
yeah. So I guess the now I wasn't really thinking this because obviously if you have some sort of force gauge and you're having to move it all around to get a a specific position to test the muscles, essentially perpendicular to the force gauge. Um, you do your general muscle test. If you find something that's weak or painful, just test that with the force, because that's really the only objective measures you're going to look at. Two questions for you. How are you rigging up that Tindec machine or device, as far as like, are you using straps or whatever? And then the other question is, and I never heard of this, why is, and this may be a dumb question, why is someone's strength supposed to be better overhead versus by their side?
So overhead is more of a closed pack position. So their shoulders should be, everything's locked out overhead. So they should have more force production there versus arm by their side.
Okay. Yeah, I've never tested it overhead. Um, but yeah, interesting. Good to know. But yeah, but then how do you rig up that Tindex device?
So I can video it and put it on Instagram and share that. But it's pretty much just how you would rig up a band for 0 degrees abduction, like internal external rotation. So I have like a handle that you would connect to a cable machine, and then carabiner clip that to the Tindec device. And then we just have like ankle straps again for that cable machine, loop it around a big bar that we have in our clinic, and then just keep it in line with their shoulder internal external rotation. So I'll do that. I like doing it in like tall kneeling or half kneeling, so they can't use as much of their legs to produce that force. And then if the person's able to get up and down, usually with the people I'm testing, they're more athletic or active. With 90-90, I'll get them supine in a 90-90 position. Again, keeping that force or that Tindec device in line with their force production. So going into internal and external rotation.
Okay. Yeah, I guess supine would probably be the ideal way, though harder to rig up just because if you're in if you're in standing or tall kneeling or half kneeling, you may have, if you're doing internal rotation, you may try to pull in the adductors too, which could create an
Yeah.
issue. So, but yeah, just looking for the compensation. I like that. That's actually a lot easier than I was thinking it would be. I don't know why. Do you do anything for flexion or abduction with those? No. Yeah.
No, I haven't really set anything up. I think that would be a little bit harder. That would be easier with like a handheld dynamometer.
Yeah. No, I agree with that. All right. Anything else to add to that before we move into special testing?
I think we're good with that. Let's get into the special testing and how we use it.
Okay, so I'll lead this off with sort of the traditional sense and how we used or were taught it in PT school, and then we can move on to how things are changing as far as special tests go. But there's a couple articles out there that we can link in the show notes that talk about and give a really good detailed description of how the original special test was created and how it was performed, because you kind of get that game of telephone where as people pass that information along, the positioning or the reasoning or what you're supposed to look for sort of changes. And then there's another article that looks at a proposed algorithm for directing your exam with special testing. And the algorithm is, again, it's another systematic way to perform an exam. I don't use it, but the article gives you the ideal clusters and then the stats as far as sensitivity, specificity, likelihood ratios, and probability. So you can kind of get a sense of what, or I guess the quality of the test or clusters. So we'll go through the rotator cuff stuff and then chat about that. And then we can move into like labral pathology and then just extra articular pathology. So the big thing that we learned in school for rotator cuff impingement or just tendinopathy was that 3 special test cluster of the Hawkins-Kennedy test, the infraspinatus muscle test, and the painful arc sign. HIP, I guess isn't that how the acronym that we used?
Yeah.
So that cluster is still, and I think the clusters are okay to do. Like, I don't know if it's really going to change your evaluation if you just look at strength and provocation, but I think the clusters are okay to do to maybe rule out a condition more than rule it in. It depends on the numbers, but so that cluster has a 10.56 positive likelihood ratio if all three are positive, which is you want greater than 10 on the likelihood ratio stuff. So you'd say that's quality. If you only have 2 out of 3, it's a 5 on the likelihood ratio. So I guess approach with caution. Um, the the rest of the rotator cuff testing is based on like a tear. So for a supraspinatus or infraspinatus tear, they talk about the external rotation lag sign, where you pull them into maximal external rotation, and I don't know, it's like 20 degrees of abduction, some sort of abduction, and then just have them see if they can hold it. They say that you can measure the amount of lag, I guess almost like a quad lag for a straight leg raise. I don't really care about that. It's like 5 degrees or something. But just to see if they can hold it and if it hurts. That has a range for a positive likelihood ratio of 15.5 to 34.5, which is solid. I think all these little lag signs and things are pretty good for a looking for like a rotator cuff tear, complete tear anyway. But again, if they're positive, you can think maybe to rule them in, but if they're negative, you can't rule out the tear. Some of the other ones was the drop sign where you just bring them up and see if they can hold it. The hornblower sign for teres minor, and then the internal rotation lag sign for subscat. They're all quality, I guess. To me, though, if someone comes in with a rotator cuff tear, that's maybe a partial tear or chronic tear, you're not going to have, they're probably not going to have obvious positives with those tests. If I have someone that comes in with supraspinatus or infraspinatus, most likely supraspinatus tears, or that's like a full thickness or large tear, that I would probably just, I'd want to send to a doc if they haven't been sent there already. Is someone's going to come in with a positive drop arm, they're like excessive shoulder hiking with abduction or flexion, and obviously pretty extreme weakness, and they may not have pain, it just might be complete weakness. But those are the people that I'm looking at and like, yeah, that might be an issue. And not to say you can't try conservative rehab with it, but it's going to be difficult. And then again, if it's a subscap issue or tear, I'm going to look at mechanism of injury. One particular case was someone running on a treadmill, and they kind of tripped and went to catch themselves on the like arms of the treadmill and forced them into external rotation, and they ended up having a partial subscap tear. The internal rotation lag sign is something you can use, but it requires the hand to be put behind the back, which can be pretty uncomfortable. So one other one that I like is the belly press test, where they put their hand on their stomach and they basically bring their elbow out away from their body to put them in max internal rotation, and they try to press in. If they can't press in without keeping their like wrist and forearm straight, so if they like press but it's really just wrist flexion, that would be a positive for a subscap tear. And this particular person had a positive belly press test, ended up being positive for a partial subscap tear, N of 1, but taking the history findings with the special test can be helpful. How do you use them for rotator cuff?
So the big ones that I make sure that I rule in or rule out are those like massive rotator cuff tears. So drop arm and external rotation lag sign. So just like you were saying, if someone comes in with excessive shoulder hiking, very limited active range of motion with decent passive range of motion, and then again, like looking at their just observation, like I've seen some people that come in with or for community screens, so just a quick screen to see what's going on with their shoulder, that have had pain for 10 years after like a farming accident, and they have no muscle, they have no supraspinatus, they have no infraspinatus. I'm like, yeah, let's go ahead and get you over to the doc and see what we need to do there. I mean, we can still work with you, but I would be more comfortable if we send you over to the doc and have them check you out. But otherwise, if someone's coming in with decent strength and they have some shoulder impingement. I'm not too worried about that. But in terms of the special tests, I will use them if nothing that we're doing with active range of motion, passive range of motion, or muscle testing reproduces their pain. So a lot of times people will come in and just put themselves in like a Hawkins Kennedy position or like a nearest position or a crossbody adduction position, say, this hurts. So that means I don't need to go ahead and just do that again to show them, oh yeah, I know this hurts, but I'm not going to do this again to them. So um, just understanding. So this is my big thing with special tests. There's that big JOSPT article saying that special tests aren't that special. I think they're important to know in terms of the positions that provoke rotator cuff related shoulder pain, as they say, but I'm not using them in probably like 70% of my evals because the patient will already tell me and put themselves in that position that hurts. So that gives me a good understanding, okay, what's going on in the shoulder. So I do like the different test clusters with like impingement in quotation marks with the hip, and then full thickness rotator cuff tear with the dip, drop arm, infraspinatus, pain and weakness, and painful arc. So I'll use those and I have them going in the back of my mind, but I don't put a whole bunch of weight with them in terms of rotator cuff related shoulder pain.
All right, I have to go back. Did you use a farming accident because you live in North Dakota?
You'd be surprised. I mean, there's a lot of tough, there are a lot of tough people up here, very, very active, hard workers, and they will just, I've seen a lot of people that have just been dealing with pain for a long time. And then they finally come in. It's like, yeah, I haven't been able to use my arm in 10 years. I'm like, man, you should have came in a long time ago. We could have got this going for you. But yeah, you'd be surprised how many people come in with non-functional arms or legs that they've just been dealing with.
Oh yeah, I mean, obviously farming is no joke.
Yeah.
But yeah, and I guess I wanted to add that the reason why if someone comes in, particularly with an acute injury that looks like a massive rotator cuff tear, you're going to want to get them to the doc just on the fact that if you let it linger, you could get some retraction and make that repair either quite a bit more difficult slash impossible, and they may end up with like a reverse shoulder, total shoulder, or something like that. But yeah, I agree. I think they're not, they can be useful. I like the idea of that if they don't have any other, if their symptoms aren't reproduced with any of your other strength testing or passive active range of motion, then maybe getting into them. But in particular for the rotator cuff, rotator cuff pathology, I guess you could say, they're not that great. There's a ton of them. They're particularly not that great in isolation. And you can glean a lot more from just watching them move than having to put them through a pain provocation test that may just wind up their symptoms even more, when really you're just looking, like I said, to get the minimal amount of information that is needed to make sure, one, there's no sinister condition going on, and two, you can start treatment.
Yeah. And another thing is it's a really good retest as you treat, like as they keep on getting better with whatever you're doing, strength, range of motion, just treatment, their painful shoulder with horizontal adduction or like a Hawkins Kennedy position should continue to get better. So you can use that as a retest versus trying to determine, okay, this is the structure that's being so-called impinged. So having that as your, okay, how much progress are you making is something that I found more valuable than using it as something to specifically diagnose a particular structure.
Yeah, I think, and we'll probably talk about this, that diagnose is kind of a weird term and has been looked at, is it necessary or not? And then can you even isolate the structures? And I know you dive into the anatomy a little bit with how the cuff blends with the capsule and things like that, but you're not really going to know accurately what structure is the issue. And I don't assume that I would know, because I don't want to educate the patient on something that I don't know for certain, because of the possible harm it could do based on fear or threat or whatever. And I don't know, I don't want to put myself into a corner. and just be willing to say, yeah, I'm not sure what it is, but we know it's painful and we know it's weak. So let's just start there.
Yeah. And I don't know what your thoughts about this. We can get into this later or right now if we need to, but an anatomical diagnosis versus movement diagnosis. So that's something that is um, very important in terms of the fellowship that I'm in, giving someone a movement diagnosis that's more based off of like Shirley Sarman's movement system impairments. I use that as well as like the functional movement systems or SFMA, giving them a movement diagnosis versus a medical or structural diagnosis. I think that's something that really helps um, with patients in terms of, okay, I can't tell you for sure what structure is going on, but I know you're limited with this, this, and this is what we're going to do to fix it or help improve those positions. Because that's really what they want. They don't care if their shoulder supraspinatus muscle is being impinged. They just want to be able to put their arm overhead.
Yeah, I'm definitely not big on structural diagnoses. Again, like I said, because you really, I mean, how do you know? Um, Particularly in the shoulder, because there's just so, I mean, particularly with soft tissue, it's just like I think of it as like just a cobweb of muscles and tendons and ligaments and the capsule. It's just there's so much stuff going on that there's just no way to know. So and plus a structural diagnosis isn't helpful. I mean, obviously a patient, that's the hard part, because a patient's going to they want to know exactly what's wrong. But you also have to balance the fact that if they think it's, I have a rotator cuff tear, even if it's a partial tear that's been there forever, and they just started getting pain, and we know that on MRIs or imaging in general, your shoulder might quote unquote look worse on the other shoulder that isn't even bothering you. So you can't even correlate it with symptoms. So I don't want to tell someone that they possibly have a rotator cuff tear, which could then limit their just like prognosis. So yeah, I like the movement, the movement diagnoses, I guess you could say. I'm not as familiar with. I mean, I know Shirley Sauerman is, but as far as those classifications, I'm not as familiar with. I'm trying to find an article, and I have it in here, but I don't have the exact words they use. But there's a study on JSPT. It's like in a head of print study, so it's not in the most recent issue, but it's called it looks at diagnostic labels for rotator cuff disease. Disease, kind of interesting word, and its relation to patient perceived need for surgery, imaging, and injections. The official title is Diagnostic Labels for Rotator Cuff Disease Can Increase People's Perceived Need for Shoulder Surgery. It's an online randomized controlled experiment. It's by Zadro et al. And essentially what it did was it took a group of people, and it's pretty heterogeneous. So it's from 5 different countries, pretty equal split between males and females. They put them into 3 groups. So one was they didn't have any history of shoulder pain. One was current shoulder pain, and one was a history of shoulder pain with no pain currently. And they had to read a vignette and kind of put themselves into their shoes. So the vignette was someone who came there with shoulder pain, or someone who has shoulder pain. It listed what they could and couldn't do, and then it pushed them into the doctor's office, and they read the doctor's explanation of what it is, of what they think's going on, and then they had a diagnosis, and the diagnosis was what was different for each group. I think there were 6 diagnoses, and that's what I'm trying to pull up. So the diagnoses were subacromial impingement syndrome, rotator cuff tear, bursitis, rotator cuff related shoulder pain, shoulder sprain, and then episode of shoulder pain. So it was found that those that were labeled a rotator cuff tear had increased perception that they needed shoulder surgery and imaging compared to bursitis. And those labeled with subacromial impingement had increased perception of imaging. It wasn't like a huge difference, but one of the limitations, I guess, which is I think good standard of practice, but in the explanation that they had, that the doctor told the patient, he or she was very reassuring, in saying that I don't think it's anything crazy. I think, with time it'll get better. So when you combine the reassurance with the diagnostic label, what is the patient placing more emphasis on? But if you have the combination of someone who's saying, yeah, that I can't believe you haven't had pain before this, even I don't know how you're functioning with that, and it's a rotator cuff tear, well then yeah, I'm assuming their perception of needed surgery is going way up. So the language is important, and when you add a structural diagnosis into it that you can't even be sure that's what it is, to me it can only be detrimental. So I try to give them what they want in a diagnosis with as minimal anatomic description as possible. Obviously, if someone wants to dive into it, then that's one thing, but you got to be kind of truthful with it. And it was funny because I was listening to a podcast back to Adam Meekins again, and I don't know if this is a kid's show or not, but he used the acronym SHITS or shits, and basically means something hurts in the shoulder. And that's all, you have something that hurts in the shoulder, let's deal with it, versus giving them a particular thing. But that article that I just mentioned, they also had an episode of shoulder pain. I think that's a good way to do it too. Yeah, anything that's less threatening, saying that you have pain with moving your arm overhead, let's deal with it. Like, that's great. Let's use that.
Yeah, for sure. I mean, I listened to that same podcast too. I started laughing out loud when I heard that. And I mean, if you have a good relationship with that person, I'm going to start using that as long as it's appropriate. It's like, okay, this is what's going on. This is where you are right now. This is where you want to get to. Let's start working on some of these things that we find. So it's just as simple as that. As long as you rule out all the sinister pathology and there's not something glaringly wrong or out of place with what you think is going on, then you can just say, hey, it hurts when you do this. These are the things that we can work on to help improve that and get you back to what you want to do. So, I mean, that's the way that I look at most things, as long as, again, we just clear out the sinister pathology, just improve movement and get you back to where you want to go.
Yeah, I think you could phrase it if someone's like, well, what do you think's going on? And said, well, I can't be certain. You have some weaknesses and some pain with these movements, so we're going to address that. And that, if that helps, then maybe it's this is going on. Or if that doesn't help, then you have a plan for what you would do next, whether you send them for imaging or something like that. But just, I think you don't want to like dismiss their like desire for, is it my rotator cuff, or is it, like my teammate had a labral issue? Is that the problem? It's okay to say, I don't know, or I'm not sure yet, but this is what I know we can do to help it. And then we'll cross that bridge down the road if we need to. So that's kind of the way that I found to sort of redirect that thought process a little bit. But yeah, I guess talking about labrum, let's move into the, I guess, intra-articular pathology in regards to instability, labral tears, and then intra-articular impingement. So I'll just run through the general tests that they like for each category, and then we can talk about how we think about these. And we'll probably get more into it when we have Wesley on for the overhead athlete, but we'll cross that bridge too. So for anterior/inferior stability, they like the apprehension test or the anterior release test. I would not do the anterior release test, just because that's kind of mean. But yeah, just bringing them back into external rotation and 90 degrees of abduction supine, and just seeing if they have apprehension with that position, as it's going to generally make the humeral head glide forward. Those have good numbers as far as positive likelihood ratios go. When you get into a Bankart or anterior labral tear, there's a pretty big cluster. It's the crank test, the apprehension test, the Job relocation test, anterior load and shift, and the sulcus sign all together. You have to have even like, I guess you could call a fair positive likelihood ratio. You have to have all 5 tests positive, and even that's only 6. So like, I wouldn't place a lot of weight into that cluster. You might want to think more of mechanism of injury in that regard, and then just, I guess, general instability. But that's I guess, again, to label it particularly as you have a Bankart lesion or an anterior labral tear may be tough. You might have a different opinion on that, but um, I guess in general, we know special tests aren't great, and those, I guess, considered to be the best, and they're not great. So, um, moving on to posterior inferior labral lesion, they have the jerk test and the chem test. They have decent likelihood ratios, and it's not a cluster; it's just one or the other or both. Um, Looking for pain or like a click or clunk with those tests. A slap lesion would be biceps load 1 and 2. And then articular sided internal impingement would be the posterior impingement sign. With not great likelihood ratios, but specificity and sensitivity look pretty good. So I guess up to you if you want to use those. How do you go about instability or labral issues?
So with instability, I really like that apprehension sign. So getting them up in that 90-90 position and going into external rotation. And if they start feeling apprehensive or tightening up, that's positive. And then if they feel more comfortable and you're able to get further with just stabilizing the anterior head of the humerus and just making sure they don't get too far into that anterior glide and they feel better, okay, that's pretty good for ruling in. It has a high specificity for anterior instability. And then making sure, again, where your symptoms are, because that's the same position for posterior impingement. So if they're getting way back into that 90-90 position and they're overhead athlete and they're getting pain in the back of their shoulder, again, that improves with like a posterior glide. That's making me think more posterior impingement. And we'll get into this with Wesley, but it's important to know, I don't know how much the treatment changes. You still have to work on all of your dynamic stability of the rotator cuff and all of that, but just important to know where their locations of symptoms are. And then with like slap tears, I like to understand their mechanism of injury and what type of like athlete or what type of activities they like. So we'll get into this again with Wesley, but with overhead throwers that have pain with throwing, that's usually what they have pain with. Their day-to-day pain isn't too bad. I'll get into more of that 90-90 throwing position. So biceps load 1 and 2, like a pronated load, external rotation, supination test, and like a crank. And if it's more of like a compressive type injury, like a fall on an outstretched shoulder or hand, I'll do more of that compression rotation test just to see if we can trap some of the labrum and recreate their pain, a positive clunk test or a active compression test. And then if it's more of a traction type injury where they get pulled, like if they're holding onto something and they get jerked forward, then I'll do more of like a speeds, dynamic speeds or active compression. So just pairing your test with a specific mechanism of injury or activity that they have pain in, again, helps give me a better idea of what's going on.
Yeah, I think like I like the apprehension test too. But you kind of know, like, are we dealing with anterior instability? Well, if they're overhead thrower, they have apprehension, and or in general, they may be lax or some sort. It's like, okay, yeah, that's what I would classify that as versus posterior impingement. So get an idea of, like you said, their activity, and then combining it with what provokes the symptoms. That can be helpful. But I don't know, I guess in the general sense, and we can talk about this in a second, but is the treatment really going to change if we just classify it as instability or loose? I'm sure there's specific things that you would do, but I don't know, especially that Bankart cluster, like that's crazy. 5 tests and it's still not even great, like utility. So it's like, I don't know. But yeah, getting your normal things and watching them move and getting their activity history and things like that is probably going to direct you more with that instability piece than a lot of those special tests. Okay, so last quick little category of special tests. These are extra articular pathologies. It's really just AC joint and long head of the biceps tendinopathy. So starting with long head of the biceps, this is not a cluster. It's just single test, Yergeson speeds, like you just mentioned, and the Gilchrist palm up test, which I am not familiar with. And I even tried to look it up, and there wasn't a lot on that. So we'll just pass, I guess. I'll use speeds for this just to see if we can provoke pain in the anterior shoulder. But otherwise, I'm not really using much, and even the stats on that aren't great. But I just want to know if I load the biceps and that that proximal portion, kind of long lever biceps load with full supination. I want to know where that hurts, just to kind of maybe tease out why in my head they have pain in the anterior shoulder. I'm not necessarily going to say it's their biceps tendon or anything, but that'll kind of help me from a treatment standpoint. And then for AC joint, there's a cluster. There's 3 tests. You have crossbody adduction, AC resisted extension test, and the O'Brien's test. And they have fair statistics on that in regards to likelihood ratios. Not sensitive really at all. So it's more of a specific cluster. And O'Brien's, I guess, if I was going to do one, and just, but really it's like, where does your shoulder hurt? And I'll palpate it. And if it hurts there, that's kind of what I'm thinking. But those are some tests that you may look at.
Mhm. No,
What do you think on your end?
I agree with all those. And we see a lot of AC joint injuries with hockey being so popular up here. So athletes get hit into the boards is very common mechanism of injury. And a lot of times they'll just have tenderness to palpation on the AC joint, just top of the shoulder. So that's a pretty quick way to rule in or rule out if the AC joint is involved. And then in terms of just the order of things, I pretty much do special tests last, because if I start flaring up their shoulder at the very beginning, then it makes everything else useless. So I want to make sure that special tests, if I'm using them, are the last thing that I do. And then palpation is, again, the last thing that I do. I know you kind of mentioned at the beginning, starting with a little bit of palpation, but I'll probably end with palpation, just making sure that I get a sense of what the tissues feel like. And then if we need to do any type of soft tissue work or manual therapy in terms of that.
Yeah, that's actually pretty smart. And I guess you could go about it in different ways. If you palpate something and it hurts, if you're for certain that you're on that structure or that area, then you're going to sort of bias yourself. But at the same point, it can kind of direct your treatment or your exam. So that is tough. Kind of got to keep in mind that, there could be other reasons why that area hurts. So yeah, multiple ways to do it. Depends on the person. Some people don't want to be touched, and you might have to build some rapport first. So it's like,
Yeah.
you got to be flexible there. But I guess, yeah, you tend to go either way. Okay, so that's the general traditional sense of special tests and examination with our spin on it. I guess we can talk about a process now that really simplifies it as far as classification per se, and then how you would treat that issue. And we will not take any credit for this. This is Adam Meakin's stuff again. I know we talk about him a lot, but he has a pretty sensible approach to a lot of things. So yeah, he has 3 categories of how he typifies shoulder pain. So he classifies them as stiff and painful, loose and painful, and then weak and painful. Stiff and painful means that there's significant loss of both active and passive movement. And he sort of defines that as more than 50%. And there's minimal pain with isometric testing. So not really a lot of provocation with contraction. You can see this in the stiff tissue, adhesive capsulitis, the stiff joint, which would be maybe osteoarthritis, and then stiff trauma such as surgery, fracture, dislocation. The loose and painful is going to be that instability that we just talked about, adverse movements of the humeral head on the glenoid, which again could create apprehension or fear. The 3 causes that he lists for that is going to be torn loose, so like a traumatic injury, worn loose, so slow, gradual instability, probably seeing like a baseball player or something like that. And then born loose would be someone with like Ehlers-Danlos syndrome or general systemic hypermobility or congenital defect of some sort. And then the last one, which is what we're going to talk about the most, probably because it's the most common, I would say, is weak and painful. So you're going to have pain with or without weakness in the shoulder or the upper arm with a particular activity or resisted testing, but you have pretty solid motion. Maybe not active, but you have pretty solid passive motion. And you can have a subcategory of strong and painful, which you're going to see more with like a strong active population. The causes for that are going to be either subacromial, meaning in a structural thought process, cuff, bursa, biceps tendon, slap tear, or AC joint, which and then the other one would be neural, something that's causing neural weakness, either from the cervical or peripherally. And then the other little piece to keep track of is sinister pathology. Then there was a new guide that came out pretty recently, and I think it's open access now. I'm not 100% sure, but it's called the Serious Pathology Guide for Clinicians in Primary Care. And there was a team of people that created that. Nikki Warren, who the other one is? Nikki Warren, Emma. Sorry if I butchered these names. Kitely, Anthony Lewis, Sean Robertson, Paula Deacon. It's pretty solid. It goes through not just the shoulder, but all body parts that possibly could have sinister pathologies in, and then defines them and what symptoms or history you might see. But for the shoulder, they had osteosarcoma, polymyalgia rheumatica, or giant cell arteritis. If they've had like a shoulder replacement, loosening, or infection from that, acute nerve palsy in either the axillary or long thoracic nerve, AVN and the humeral head, and then a DVT. So just things to keep an eye on. You can look those up if you want to. You can look that guide up if you want to have a little bit more information on that. So that was a lot, James. Do you want to move into treatment for those, or do you have anything to touch on as far as why you like this process?
We can talk about the process. So I think a lot of treatment categories or patient classification categories are very helpful because, like we talked about, we want to get a movement diagnosis, but these different categories help guide your treatment. So they're able to put patients in different categories to help make sure that you're not getting lost with all the information, especially for younger clinicians that don't have as much experience, or they don't have that pattern recognition. Then this is a good way to begin your thought process in your treatment.
Yeah, I think it's simple. I think it sort of gives you three categories, because we talk about like, okay, if you have, let's say you have the Hawkins-Kennedy infraspinatus and painful arc, and you're like, okay, they have impingement. That doesn't really change your rehabilitation or treatment from like some rotator cuff related pain. So these categories are almost, they guide your treatment. So if you have a stiff and painful shoulder, you're probably going to work on mobility and trying to reduce pain. If you have a loose and painful shoulder, you're probably going to work on stability. If you're weak and painful, you're going to work on strength. So like you said, that this can be a pretty simple way to build that pattern recognition, avoiding too structural explanations, I guess.
Yeah, and just not getting overloaded with information, because I mean, again, if you're collecting all this information, you might not know what to do with all of it. But if you're able to put everything into a category, it just makes it a lot simpler.
I think those categories are good. People can move from, I don't know, maybe stiff and painful, then the stiffness is gone, but now they're weak, and maybe those ranges that they could not get because they were stiff. So yeah, people can change categories and just kind of adapt your treatment to that. I'm going to dive into a little bit more assessment and how I would do my assessment with these categories. And you can add on to that if you have things. I know we've talked about it a lot. But some of the things I would look at that I don't believe I touched on as far as history goes is patients' medical history or lifestyle as far as smoking, alcohol use, their physical activity, how they're sleeping, and their stress levels. I know shoulder pain can be worse at night. Whether that's related to positioning or not, it's hard to know. And it's correlated with just in general increased pain in certain patients. So that's something. And a couple other things would be diabetes and just general obesity. So just getting an idea of those things. If someone comes in, I've had a lot of people come in with um, especially where I used to work in South Carolina with rotator shoulder pain. Yeah, the shits, I guess. And uh, something hurts in the shoulder, and they have a history of smoking. They still smoke. They have different comorbidities that are going to affect pain. They're not sleeping. So if I give them some strengthening exercises, it's probably not going to do anything. Like you have to, there's so many more layers to that exercising. I mean, exercising can certainly help, but if you're not seeing progress, it's probably because it's not necessarily the issue of the shoulder. It's just kind of a systemic issue. Um, Moving into the exam in general, and this is again Adam Meakin's process that I've kind of adopted, is we talked about it: observe it, palpate it, move it, and then resist it. So the first two kind of speak for themselves. Movement is just watching them move, or you move it, have them demonstrate the painful activity, and then resist it's just looking at strength. He does talk about some special tests, and as far as the clusters go, I won't go back into that, but he does utilize those. So again, if you want to finish your exam and not knowing what exactly it could be, you could jump into those. Anything else to add to that?
No, I think we pretty much covered it.
Yeah, kind of beating that one into the ground. You want to start with treatment, how you would go about it, and I'll go with what I do.
Yeah, so we're going to focus on the painful and weak shoulder. So a lot of times, generalizing, someone will have limited shoulder internal rotation. So I know there's a lot of, in school, we were taught, okay, the person has posterior shoulder capsule stiffness. So you have to do your manual therapy, your posterior glides into that position. So we know that there's a million reasons why manual therapy will work in terms of the not just biomechanical reasoning. So I like starting with improving movement. So if they have limited internal rotation, some things that I'll do, I'll start with shoulder like manual therapy. So getting them into the position of restriction, I'll start with posterior glides, inferior glides, and then just supine 90-90 internal rotation stretching with, I call them like pails and rails, which is more like a FRC type of deal, but you can think of it as PNF. So resisting back into you and then stretching and then holding that position. So you're adding a little bit of active input into that stretch. So that's usually the first thing that I've started with, just to open up shoulder internal rotation and get a little bit more movement in their shoulder. And then depending on what we find in terms of weakness, usually they'll have a lot of posterior cuff and scapular weakness. If they have pain with shoulder external rotation, I'm probably not going to give them a sideline or band shoulder external rotation. So I'll start with more scapular strengthening. That could be prone, banded, anything just to get more in terms of the typical patient, lower trap and middle trap strength and scapular motor control. So those are pretty much my go-to things that I start with. Anything else that you like to add?
I start with that advice education piece. I feel like if the patient doesn't, I'm trying to build a foundation. So if the patient doesn't know what's going on, or they're unsure about the plan, or they're scared or whatever, then if you jump right to the exercise or manual, they don't really know what they're doing. So that helps. And I talked about that study that looked at the diagnostic label. So trying to avoid using those things. So I try to give them why it hurts, possibly kind of how that system goes, and then ideally an estimate of how long it's going to take to get better, with probably a bit of an overestimation. So I'm not putting pressure on them or myself to like get it quick. If they get better faster, you look better. And then I'll get into just in general trying to encourage movement. So if someone is afraid to move, then I'm going to try to get them to comfortable with moving their arm, whether it's not even their arm at first, it's something else. Or they're afraid to lift their arm. So I just start with like rowing or something like that. And then if there's someone who you'll see the people that are just doing way too much, then I try to reel them in a little bit, just to get things to calm down. And then I'll move into strength kind of as that third tier. That's kind of been at least lately, the gold standard for shoulder issues. And the progression is going to be based on the person, but in general, I'll do, if they have pain with doing a certain motion, like you said, I'm not going to necessarily have them do that right away. I'll have them move the shoulder in a different way. I'll probably start, if they're a little bit hesitant, I'll probably start in like a supine, sideline, or prone position, and then maybe with some isometrics. I don't think necessarily there's research out there that shows isometrics can help reduce, that can be analgesic. I don't think I've actually found that to be true in the patients that I've worked with, but I think it does give them an idea like, oh, I can create force with with these muscles, and that makes them comfortable with more isotonic stuff. The then progression into standing stuff, straight plane, then diagonals, then dynamic movements, and then kind of paying attention to that kinetic chain, like we talked about. If they need some, you think they'd benefit from more mobility in their thoracic spine, if they have some, they're really tight in their lats or something like that, and they're trying to do overhead press, like that could be an issue. So looking at those biomechanical factors if necessary. And I don't get too dialed into scapular positioning because there's a lot of variations, but I will obviously work on the parascapular muscles, just from a strength standpoint. If there's obvious dysfunctions like extreme scap winging or something like that, well then yeah, we're either concerned about long thoracic nerve issue, or let's work on serratus. But yeah, otherwise those are kind of my three. I know we sort of have different opinions on manual therapy to a degree, and I'm trying to like not, I don't know, I tend to not use it, but I know there's places for things, and I don't want to get too far into one camp. So I know it kind of, there's a middle ground for it. So I guess let's talk about that, and then we can include dry needling in that because that's considered manual therapy. So when do you prioritize manual therapy, or do you use manual therapy if you need to use it?
I think it all goes back to the assessment. So if I find that someone is unable to get into a position that they need to be able to get into, so like say someone doesn't have any thoracic spine extension rotation that's limiting their shoulder flexion mobility, I'll start working on their thoracic spine. So if it's a quick manipulation, we know that's a safe area to target with very little side effects. So why not give a quick thoracic manipulation as long as you're okay with it? It takes 2 seconds. So I'll start with that and retest, see if they're able to get more extension rotation, see if their shoulder overhead position gets better. And then, so say that doesn't improve, and we find that they also have restricted lat mobility in our assessment, I might do some quick soft tissue work to their lat, teach them how to work on a foam roll, a cross ball, or a band, doing like PNF stretching for their lat, and then again, retest. So it all goes back to your assessment. Manual therapy is great to be able to improve positioning, and I don't really spend more than 10-15 minutes on it. But if someone can't get into a position and I can help them, I'm all for that in terms of hands-on work. And we'll get into dry needling later, but what do you think about that?
Yeah, like I said, I think I like active treatment as best as possible. Like that is my full priority. My issue, my only, multimodal treatment has been shown to be highly beneficial. I know thoracic manipulations have been shown to be beneficial for the shoulder. Dry needling has research to benefit the shoulder. So I don't want to like not use it because I think there's points to it. My biggest question that I've always battled with is like, what is it even like? What is it doing? It's not lengthening muscles like from a shortening standpoint like that. You can't change that fast. You're getting quick changes, which can then adding some sort of exercise possibly to get them into that position, or like like an in-range liftoff or something like that. You get them some more external rotation with passive stretching or something like that, and then you have them work through that position, kind of like with the pails and rail stuff. I think that's beneficial, but at the same point, I don't want them to think that they need that to get them where they need to be. And the only, and that's easily avoidable just by how you frame it. Um, so say, hey, we're going to do this because it'll probably help you get a little bit more motion, and then we're going to work through it. And as long as you keep doing X, Y, Z, um, you should be able to maintain that change. You should be fine. You're not going to need this every single time or forever. This is just something that may kickstart it. But I'm not sure how to describe it, because a lot of times a patient will come in and say, I just think my pecs are really tight, or in the case of like maybe a lower extremity issue, I think my hamstrings are really tight. And I don't want to get too in the weeds, but like, what does tight necessarily mean? Like, are they short? Well, if you can stretch for 30 seconds and now you can go farther, you're not short. So it's probably something with the nervous system. Is tightness, I don't know where I heard this described, because I definitely am not smart enough to make it up myself, but is tightness more of like a sensation, like an itch? So if I start to itch, I scratch it, it goes away. Whereas I feel tight, so I'm going to do something about it. And that may be stretching or soft tissue, or dry needling or something like that. With dry needling's even more like, I don't understand how it works, because sometimes it's literally like magical and I don't get why. But
Mhm.
it's as far as those immediate changes, why is that happening? And I don't, sometimes it can be as simple as describing it as, yeah, you're tight and we loosened you up, because that makes sense to the person. But at the same point, like driving those narratives in over and over, the patient's going to be like, well, I'm tight again, I need to go back and get this done because that's what helped the first time. So that's my biggest thing, is like there's a lot of unknowns with it. And I think if you, even the old traditional stuff are like, yeah, this is out of place, we just put this back in place and now you're fine. Like that's the extreme. And I definitely don't agree with that. But we know soft tissue and manual and manipulations and things like that will help. Why that helps, I'm not sure. And I just like to be able to educate the person and not, jump to conclusions. Um, and in general, I would for sure go with an active, or even just something that they can do on their own, so they don't feel like they need me, um, over trying to do in a passive technique. And the other point is, you know, people like to be touched, like I said, like they like to have that, and I think it builds rapport and trust in what you're doing. So it's all about outcomes. And if someone feels like they had dry needling and it really helped the first time, well, then I'd be dumb not to do it again. So yeah, it's tricky. It's a constant battle, because I know both are important, to a certain degree, particularly when you look at patient outcomes over just like what the research says. But I also don't want to drive a narrative that could be detrimental in the long run. So
Mhm.
that's tough. That's a long way of saying, I don't know.
Yeah. So something like, I completely agree with you. Like I tell them, I'm not putting anything back into place. I'm not breaking up scar tissue, but we're just giving input to your shoulder to help it calm down and help you move better. That's pretty much as simple as that in terms of what I use. So I just make sure that they understand, hey, we're not breaking anything up. Your spine isn't out of place, but I'm just helping you move better, helping something calm down to get you into a better position, and teach them how they can do that themselves, and then train into those different positions to help keep that whatever we're working on. So keep that mobility or keep that strength into the position that we're working on.
Yeah, I like that. I think just leaving it as, yeah, we're gonna do this. It should help you move a little bit better, and then we're gonna work through it. And leave it at that. Not, because even if you said we're gonna do this, and we're gonna, like some people say, put input into the system, and it's like I don't even know what that means, and I'm assuming the patient doesn't really know what that means. So leaving it as simple as, yeah, we're gonna do this. You should feel like you can move a little better afterwards, and then follow it up with whatever you are doing. Um, I kind of go up against, and I don't know if we have different opinions on this or not, but like the correctives piece is like we're gonna do a manual technique and then we're gonna follow it with correctives and then you'll be fine. Since typically, I mean, with a lot of stuff, it doesn't really matter what exercise you're doing as long as you're doing something. But again, that narrative can really help someone get a sense of why they're doing it, and it may help them stick to it better, which, whether it's that exercise making the particular difference or just exercise in general helping, it kind of goes back into patient outcomes. But yeah, I think I think that's a good way to do it. Just say, hey, we're going to do this. It should help you move a little bit better. You may feel a little bit better, and then uh, move on to the next treatment. Because even strength training, there's stuff coming out about strength training, which has been super. I mean, it's been a big emphasis in it for good reasons. Like being strong is helpful in a lot of ways, but when you're quote unquote strengthening someone's shoulder um, in physical therapy, but you're not following the suggested guidelines that's promoted by the National Strength and Conditioning Association, as far as the required intensity or resistance you need to use versus rest versus reps, then you can't be sure that you're strengthening. And through various studies, there's things that say that, you don't need to get officially objectively get stronger for your symptoms to go away. So then that comes into question. It's like, well, why is strengthening helping? I mean, obviously for some people getting stronger can absolutely help, but for others, it could just be that you're all of a sudden the patient they're challenging what they thought they could or couldn't do, which can reduce just fear or threat of moving. It could just be regression to the mean that's happening that just happens to happen while you're strengthening. So I don't know. It's all like, what are we even doing?
Yeah.
Just pick like something that the patient, don't drive a harmful narrative uh, and yeah, don't drive a harmful narrative and kind of get an idea of what the patient feels like they may need. Use your obviously expertise too, but um, even the highly touted strengthening stuff can be, not what we thought it was.
Yeah, and a lot of it is sometimes people just gain a lot of confidence from being able to so-called strengthen their shoulder or actually get back into working out. I mean, movement creates a whole bunch of endorphins, so decreases pain there, and then just gives them confidence. Hey, I can actually do this with my arm. I wasn't able to do this a couple days ago or a couple weeks ago because either they were afraid to do it or it hurt them. So just gradually stressing the patient, because stress leads to adaptation. So just adding a little bit of stress to their shoulder or whatever you're working on over time, I mean, it should get them better and
Yeah.
help improve it.
Yeah. I think stress leads to adaptation is good in a physical and I guess I don't want to say mental state, but if you do something, there's going to be hopefully a change and hopefully that's positive. Um, and I think that's why the multimodal stuff is good. And I think that's why it's hard to say why it's good. And I think it's good to be skeptical. But you can't be like that paralysis by analysis where you're just like, well, why am I doing that? Why am I doing that? Because then your outcomes may not be what they could be.
Yeah. Yeah. So I think the way that I try to think about it is, okay, if someone is painful or unable to get into position and exercise or stretching isn't helping, what can I do to help facilitate that with hands-on work, manual therapy, dry needling? Okay. And then, so they get into a better position, and then you can isolate your shoulder. Okay. Make sure that they have the required things that a shoulder needs to be able to do, required range of motion, required strength, and then start integrating that into normal strength conditioning movements, horizontal, vertical pressing, horizontal, vertical pulling, just getting back to those so-called functional movements, air quotes. So you're kind of hitting that whole continuum.
Yeah, I think, and then
Yeah.
just pushing that into whatever they want to return to activity wise.
Yeah.
The last piece I'll say on the manual therapy, and we can talk about dry needling after this, is it's definitely population specific too, because when I was the last place I practiced, it was a lot less acute injuries and a lot more chronic injuries. And I am not going to emphasize manual therapy with that population as much as if it was an acute injury, which may be kind of backwards as far as the decreasing threat stuff. But I think that self-management is super important to just increase self-efficacy, which can help. So population specific for sure.
Yeah, definitely.
You do more dry needling than me, so you want to just talk about maybe how you set that up and what you like to do.
Yeah, so I use I think we've talked about this on the Achilles podcast, but I was trained through the Spinal Manipulation Institute and James Dunning's group. So I use more of that electrical dry needling approach where it's a semi-standardized protocol. So I'm not trying to find the so-called trigger points and go ahead and piston in and out of the so-called trigger points that I find. So there is a, like I said, that semi-standardized protocol that's hitting different points in the infraspinatus muscle belly, the supraspinatus, the tenoosseous junction of the supraspinatus, deltoid insertion, brachialis, and then there's also some other optional points that you can use. And this is all in a paper that was published in JOSPT earlier this year. So the name of the article was Spinal Manipulation and Electrical Dry Needling in Patients with Subacromial Pain Syndrome, a multi-center randomized controlled trial. And the purpose was to compare the effects of thrust manipulation to the cervical spine, thoracic spine, and ribs in electrical dry needling to those of non-thrust soft tissue and joint mobilizations, exercise, and then IFC, interferential current. And they were able to put the different points in that article. So if you're interested in the semi-standardized protocol, it's all listed there.
I'll have to look that up.
Yeah. And they're usually pretty strict in their courses of not like sharing their protocols, but they do a lot of great research and they have that fellowship program where everyone is part of their research group. So some of it's biased because it's all from people that are in their fellowship and they want the research to be good. But I've gone through a lot of their classes and it's been great. I really like their ways of doing things. But in terms of their results, they found that 10 sessions of thrust manipulation to the cervical spine, CT junction, and ribs, along with dry needling, resulted in greater improvements in shoulder pain intensity and shoulder-related disability in comparison to the general manual therapy, soft tissue, and exercise group. And that's I think that's pretty cool because we know exercise is the biggest thing that helps improve shoulder pain and weakness type deal, subacromial impingement syndrome. So the fact that they didn't even do exercise and they had greater results in the spinal manipulation and dry needling group was superior to exercise. So I thought that was pretty cool. And just imagine if you are able to do thrust manipulation, dry needling along with exercise, just imagine the results that you could get.
Yeah, I think that's interesting. And I think that again, I mean, I don't know what the term is, but the more you add to the situation, probably the better outcome you're going to have. So there's a study that says exercise versus exercise and manual therapy, it's like, well, you have the addition of something, so it's probably going to be better. At least it's not going to be detrimental anyway. So yeah, I don't know how to because I think I saw that study, but I didn't really dive into it. My other question is how long are you seeing the benefit, or I guess how long is the follow-up, I guess, or what do they look like? I mean, one of our goals should be to get someone better and out of the system, like for good. So the long term is always something I like to look at. But yeah, I think combining exercise and any sort of manual therapy or dry needling that's probably the standard of care, because even exercise alone isn't something that's like mind blowing. It sounds really good and it should be the cornerstone, but not the only thing. And I found that if people have heard of dry needling, they're probably going to do good with dry needling. If they're scared of needles, then I'm not going to do it. So
No.
yeah, I think that's something that can be wildly useful in the right population. Anything else in regard to treatment? I feel like we covered most of the stuff I was looking to cover.
Yeah, that's a big part of it. I mean, most people listening to this have their general exercise approach to treating patients with shoulder pain and weakness. So I think there's a lot of research, even studying for the OCS, there's a lot of research that just shows that adding, like you said, that multimodal approach, adding manual therapy or hands-on treatment to exercise does produce better outcomes. So even if it's just 5-10 minutes of adding something hands-on can be beneficial to the patient as long as it's something that they believe in.
Yeah, and I think just the last point that I would make to summarize is just grounding those treatments in a explanation that's not harmful, making sure the patient is educated on, the plan and what's going on, and then obviously, like, primarily, and sometimes this is the only reason, I don't say one of the main reasons someone could get better is because they like you, like you have good rapport. So having a foundation in that, and then deciding the treatments, and always having a plan if something doesn't work out the way you thought it could. So yeah, what resources do you use as far as people or journals or whatever, to get a little more information about the shoulder?
Yeah, so my go-to with the shoulder, I think we mentioned this last week, would be like Mike Reinold, Kevin Wilk, Lenny Macrina. So those are the shoulder experts that I like to follow, and they do a lot of clinical research. So they have articles in Sports Health and International Journal of Sports PT, JOSPT. So those are the main resources that I get. And then along with functional movement systems, I really like their assessment approach. Sometimes I don't always use their treatment approach with exercise, but if it works, it works. What about you?
I have Mike Ronald and Lenny Macrina down. My two favorite are Jared Powell and Adam Meekins. Adam Meekins is the sport physio, and I can't remember what Jared Powell, a shoulder physio is Jared Powell on Instagram, shoulder_physio. I think they put out really good stuff, and Jared Powell was on one of the wrote that editorial on JSBT about what is strength really doing with shoulder pain. So those guys are good. Todd Ellenbecker, he wrote the current concepts, 4th edition, the shoulder section. So he had a lot of good stuff in there. They're coming out with a new version of that, so I don't know if he'll be on their new version or not. But yeah, so he has some good stuff too. Those would be mine. I think that's it. Again, I have no idea how long that was. Hopefully it was helpful. You want to close it out, James?
All right. So thanks everyone for listening to the podcast. Next week, we're excited to bring on Wesley Talley, one of our former classmates at MUSC. He has done a sports residency at ATI/Pro Access, and he specializes in treating athletes with shoulder pain, overhead athletes. So thanks for tuning in, and looking forward to hearing from you guys. Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.